So here we are now, back at it with cardiac physiology. Last video we finished up the pressure volume loop. We also talked about the cardiac and vascular function curves. We discussed how it changes, what the various different images you can get on your step 1 are going to be. You don't really see this on NBME too much, but it's definitely going to be on step 1. You're going to get a cardiac vascular function curve. You're going to get your pressure volume loop, or at least one question on this, right? And we talked about all the different variations you can have on this diagram. And then what was left now was to look at your cardiac cycle, right? So this fusion of, what is this, 1, 2, 3, 4, 5, 6, 7 different things, I guess, 7 different lines being graphed at the same time, and they go together because all of these things happen at the same time. Now you can actually memorize this entire graph and reproduce it again because you're supposed to know all of this already. For one thing, you should know each one of them individually very well, each one of the 7 lines very well, and then how they come together is also a thing of beauty that just like falls into place. There's nothing difficult about actually being able to memorize and reproduce this entire 7-line graph. Note that the x-axis here is your time, right? So going from 0 to 0.8 seconds, right? So basically all of this, everything that you see here is happening within 1 second, right? Even 1 second has not passed yet. This is 0.8 seconds. So within 0.8 seconds, every 0.8 seconds, this happens. This entire cycle of stuff happens, right? So that's your x-axis. On the y-axis, we just have a little one up here for the whole ventricular part, where your y-axis is denoting your pressure values, right? So now pay attention to the title and label of each one of the lines, and on the top there are labels for these vertical lines that we have, just separating systole and diastole and putting in these names for isovolumetric contraction, systolic ejection, isovolumetric relaxation, and then diastolic filling, right? So rapid filling and reduced filling are basically diastole, that's diastolic filling, just like this was systolic ejection. Systole is contraction. So those same names come over here too, right? Starting with atrial systole. Then during the whole ventricular systole, you have isovolumetric contraction, rapid ejection, where the aortic valve has now opened, so you're putting blood out of the left ventricle into the aorta, and then reduced ejection, where you're about to close your aortic valves because your left ventricle is done sending out most of the blood. Then you start diastole, which is exactly where the aortic valve closes. You get your dicrotic notch, remember, because this is where when your aortic valve closes, some blood comes back down the aorta, and you get a second pressure bump over here, and some blood goes into your coronary arteries, right? Left and right coronary arteries. So that happens like right around here, right? Then you have ventricular filling pressures, where you're just filling up your left ventricle, right? So that's what diastole is all about. Very easy stuff, super memorizable. Pressures are all understandable too, right? You know your 120 over 80 is your standard pressure. So 80 is where the aortic valve opens. 120 is as high as it goes before the aortic valve is gonna, come back down and close again. So let's take a look at each one. The first curve we have is this pink one that we just kind of traced right now, right? Aortic valve pressure, right? Aortic pressure. This pressure is pretty much going to be between 120 and 80. Because that's your normal blood pressure, and remember, afterload has to do with blood pressure and your aortic valve. So you can see it just follows along the left ventricular pressure, right? For as long as it's low, it stays low, but when your ventricular pressure starts going really high, above 80, it follows your ventricular pressure, right? It should always follow your ventricular pressure. If it does not, something's wrong. And then when your ventricular pressure starts coming down, there's this one little bump here where we said the coronary vessel gets perfused at this point right here, right? This is where aortic valve closes. After that, in this bump up here is where your coronary vessels are being perfused, and then your aortic pressure starts going back to normal again near 80, and this is a cycle that's going to keep repeating. The purple line here is your left ventricular pressure, right? So left ventricular pressure is going to be extremely low when you're in atrial systole, right? Atrial systole happens. Then you have your systole phase, where your ventricle is going to start contracting. And this is where, during systole, is where your ventricular pressure is going to be super high, right? So as it starts contracting, there's this isovolumetric contraction part, right? Because you're supposed to look at the purple curve and the red curve together. So before I keep going, let's look at the red curve too. The red curve is your left ventricular volume, right? So left ventricular volume, and then you have your left ventricular pressure. So the y-axis basically changes based off of what curve you're looking at. If you're looking at the red one, then basically now you're looking at volume going up and down. So in the beginning, you have a tiny thing here. Then you see how it's flat down here. This is isovolumetric contraction. During this flat phase where your ventricular volume is not changing, this is isovolumetric contraction, which means your ventricle has just started to contract, right? And in between here to here is less than 0.1 seconds of time. So keep in mind that this is a very tiny thing that happened. Nothing massive happened. Very, very tiny thing happened under, in less than 0.1 seconds. A tiny thing happened known as isovolumetric contraction, where contraction has just begun, but blood hasn't left the left ventricle yet, right? This contraction keeps happening until enough pressure builds up that the aortic valve opens up. Once the aortic valve opens, you can see left ventricular volume plummets downwards. The ventricular volume decreases like crazy because all that volume from the left ventricle is now leaving and going into the aorta, going into your body, right? So the pressure goes really, really high, up to 120, and then starts slowly coming back downwards, and that's when your ventricle is pretty much empty now, right? So when your aortic valve closes, right where the dicrotic notch happens, you've pretty much ended systole, and you're about to start doing diastole now. So you can see that although this is still empty, eventually, right, you have your isovolumetric relaxation first, right? Just like you had this flat plateau point here where you had your beginning of contraction, you also have isovolumetric relaxation where the ventricle is still empty, but we are in diastole now. We're about to fill it, but we are about to fill it. We haven't started filling it yet. So this first part of diastole is isovolumetric relaxation, where it's contracted. It's really, really tiny. The space inside the left ventricle is really, really tiny, and then it's about to start relaxing, but it hasn't completely relaxed yet. Right? So this space here is also within 0.1 seconds, right? 0.4 to 0.5. Within 0.1 seconds, you have your isovolumetric relaxation, where the relaxation has just started, and then within the next few 0.2, 0.3 seconds, you have the rest of relaxation, where everything is going to be coming down pressure-wise for the left ventricle. And once the pressure in the left ventricle gets super, super low, your mitral valve can open into the left ventricle now, start filling up the blood into here. Right? So this entire pressure going down part is the plateau phase here of isovolumetric relaxation, where you're not adding blood into the left ventricle right now, but you are in diastole. As soon as the mitral valve finally opens again, boom, you see left ventricular volume starts filling up because you're putting blood from the left atrium into the left ventricle. Right, so that's it. And you can see the labeling for the mitral valve closure and open, mitral valve closure and open, and the aortic valve closure and opening, and all of that stuff, right? So it's all put onto the graph as well. The last line we have here is this green part here, right? This green part here is your left atrial pressure. Now, the new thing they did in 2019, as opposed to the 2018 book, right, is in this left atrial pressure part, they also labeled the A, C, X descent, V, and Y descent that you're supposed to have in your JVP, right? Where your JVP is actually your right atrial pressure. But you can see that there is a connection, there is an overlap between right atrial pressure and left atrial pressure. They're pretty much the same. And if you have trouble memorizing your JVP curve, then you shouldn't, because it's the same as this one over here, which you've looked at many times every time you look at your left ventricular pressure curve, right? It follows the left ventricular pressure curve as well, right? So you have your first part over here where you had your atrial systole, right? So either left atrial, right atrial, doesn't matter which way you're talking about. Both atria are contracting at the same time, your left and right atria. So when they do contract, you have your A wave of the JVP, right? That's atrial contraction. You can see that right here as well. And atrial contraction, or the A wave, will always be absent in both your QRS when you're looking at it, right, which is the P wave here, as well as your JVP tracing, right? Because atrial fibrillation basically means your atria are contracting nonstop in very weird rhythms, pretty much non-rhythmically. So when that's happening, you don't really get a clear A wave. You don't get a very discernible P wave on the ECG, the QRS stuff right here. Same thing on the left as well, right? This A wave, if you have left atrial fibrillation, you're also going to have the same thing. Atrial fibrillation is usually left anyway. but it can be in both sides, and it kind of messes up everything, left and right, so it doesn't matter. Both of these A's are going to be messed up. So this A wave over here for your left atrial pressure is also going to be messed up, right? You have your A wave. When the pressure for your left atria is very, very low, that's when your mitral valve has pretty much closed, right? You have your mitral valve closed, and this C wave happens here, right? This C wave happens now because this is exactly where, right? This C wave is also contraction, but this contraction is for your left and right ventricle, right? So first you had atrial contraction, that was your first bump. Then the second bump is your ventricular contraction, right? When your left and right ventricles contract, when your left ventricle contracts, your left atria gets more pressure in there because some of that pressure is being emitted back up the mitral valve. Same thing on the right side. Remember, your JVP tracing is everything above your tricuspid valve. There is no valve besides the tricuspid valve on your right heart as far as any of this is concerned. The pulmonic valve doesn't really count. So when your right ventricle contracts, same thing happens. A lot of pressure gets emitted backwards up the tricuspid valve, and you can actually sense it on your JVP tracing. So that's the C wave over here, same kind of C wave over here as well. Then you have your X descent. Now in both of these places it's the same thing, but just a different valve. So over here your X descent is related to the mitral valve. Here your X descent is related to the tricuspid valve. Right? This is happening while you're ejecting all the blood out of the left and right ventricles. When you're injecting all that blood out of them, the tricuspid valve kind of bends downwards into the ventricle as well, because it's dead empty in there, right? So this is a downward displacement of the closed tricuspid valve during rapid ventricular ejection phase, right? So downward is just opening into the, not opening entirely, but there's a downward displacement into your ventricle. And since that's a downward displacement, there's lesser pressure above it, right? There's lesser pressure above the tricuspid valve, lesser pressure above the mitral valve. That's why you get a descent, right? And during this entire descent phase, you can see systole is happening, right? Systole is happening during the entire X descent because your ventricles are contracting and sending blood to wherever they're going to send it to, depending on which ventricle it is. At the end of systole, you have this 0.1 second time phase, right, where you have your isovolumetric relaxation. Nothing happens on either one of these curves until eventually you get the V wave, right? And this V wave is in diastole, so that's ventricular filling, right? They call it ventricular villing if you want to do it, but you really don't need that, right? It's just common sense. You can see by this point we've reached the diastole part, so any pressure changes we see are going to be related to diastole, which has to do with filling the ventricles. When you finally start adding a lot of blood into the ventricle, right, you're going to have pressure in the atria, so that's why you're seeing that. That's all it is. Increased right atrial pressure because of filling against the closed tricuspid valve. Right, so right now in this early diastolic area, up here for the mitral valve, this is everything after mitral valve closed, right? You get your V wave at the same time your mitral valve closed. When your mitral valve closed, and then imagine the same thing for over here for the JVP, your tricuspid valve closed. Now you're adding some blood into your atria, and the valve is closed, so whatever blood you're putting into your atria is building a pressure upwards into your jugular vein and into your above your mitral valve, right here for the mitral valve tracing. Right, all of this is diastole. This is all diastolic here. V and Y are both diastolic here. Right, so V was filling it. Then what's happening with the Y wave? Well, the Y is a downward pressure. That means that you must have opened up the valve again or something, right? And that's exactly what it is. Your mitral valve did open, right? It was closed this entire time, and you were filling it, and you continue to fill it until it opens, and then you start putting blood into your ventricles again. Right, so that's all there is into this entire thing. And you can see the overlap here. Right. Now the other thing you want to watch out for is just up here, just this top portion up here. You get questions where you get just this upper graph, nothing else. Right. So these first three lines, you want to make sure that the aortic pressure follows the left ventricular pressure, and you have your dicrotic notch. You want to make sure that the mitral pressure also follows the left ventricular stuff in the beginning as well as in the end. In the middle, your mitral valve pressure should never be that high, right? Your left atrial pressure should never be very high. If it is, that's a high PCWP. That's a problematic thing, right? So left atrial pressure shouldn't be high at all. And make sure that your total ventricular and aortic pressure up here doesn't really go much higher than 120. Because if it does, then that's pathological. There's something wrong, right? The only thing we haven't talked about in this entire graph so far were your heart sounds, right? So now we can see the association of these heart sounds with different parts of stuff that's happening. So S4 happens during atrial systole, when your atria are contracting and putting blood into the ventricle, right? That's what atrial systole is. So S4 is considered to be in late diastole, right? Because when your atria is contracting, that means you're filling your ventricle, and if you're filling your ventricle, you're in diastole. This is also known as an atrial kick. It's best heard at the apex with the patient in their left lateral decubitus position. High atrial pressure is what S4 basically means, and that's associated with ventricular non-compliance, either by ventricular hypertrophy, maybe because the patient has a history of MIs, so now the ventricular wall doesn't really expand very well. Left atrium must push against the stiff left ventricular wall, considered abnormal regardless of patient age. This is never considered normal, right? So it shouldn't be very prominent. The way you see it here is okay, but if it's more prominent than this, you actually hear in S4 very, very well, then that tells you that your left atrium is having trouble pumping blood into your left ventricle because your left ventricle is too stiff, right? So often after an MI, when you heal the wall, it becomes stiffer than it was before the MI because of all the extra collagen. Another reason your left ventricle could just be stiff is because you actually have hypertrophic obstructive cardiomyopathy, or you have hypertrophic cardiomyopathy due to hypertension, chronic hypertension, right? All of these are different pathologies that can occur that can make you have an S4. So the question will literally tell you, or you hear something in late diastole, right? A late diastolic heart sound is heard. That is called S4. That's your late diastolic heart sound, right? Systole, it hasn't started yet, is right before systole, or a sound is heard right before systole. If they're being extra nice, they'll tell you you hear an S4, but they can just describe it instead. And they might even ask you, how do you make the S4 louder? So you put the patient on their left lateral decubitus position, and you're going to hear it louder at the apex, right? The reason it will be louder at the apex, remember how heart sounds work. If your left atrium is contracting, blood is shooting towards your left ventricular apex. So that's why you hear it better in the left ventricle apex position. That's the direction vector of which blood is flowing, right? You want to look at the vectors of which way is blood flowing. Every time you think of how do you hear a certain heart sound, how do you hear a certain valve, how do you hear a certain flow of blood, you hear it based off of the vector of flow. Which way is blood actually flowing, either through the valve or before that, right? So that's what tells you whether it's like a regurgitation or if it's a stiffness, etc. And we're going to see the heart sound soon enough too. So that pretty much covers S4. S1 and S2 are the normal heart sounds we always hear, right? S1 right here is going to be mitral and tricuspid valve closure, and it's louder in the mitral area. All right, so down here, all the way down at the bottom left, and we're going to see where you're supposed to hear these heart sounds. That's S1, so you can see mitral valve closed, aortic valve opened. S2 is aortic and pulmonary valve closure, which is loudest at the left upper sternal border, up here. Right, left upper sternal border right here is, so the sound waves are usually A, P, T, and then M is the further down to your left. So we're gonna see the heart sound soon enough. That's S1, that's S2. S2 right here, you can see mitral valve is opening, aortic valve closed. So always associate the other half of the heart as well. If your aortic valve closed, that means your pulmonic valve must have closed, and that's where you first hear S2. It starts at the closure of this. S3 is another heart sound you could hear, right? And S3 and S4 are both in diastole, but you have to remember S3 is early diastole, S4 is late diastole. And they always describe heart sounds like that. They'll tell you, oh, you hear a late diastolic sound, or you hear an early diastolic sound. S3 is an early diastole during rapid ventricular filling, associated with increased filling pressures either due to mitral regurgitation or heart failure, and more common in dilated ventricles, but can be normal in children, young adults, and pregnant women, right? Because pregnant women have extra volume in their blood, young adults are pretty athletic, children are just also very, very jumpy and athletic. There's really, in those places it could be normal, but you don't always want to assume it's normal. You want to look at things in a pathological way. It's most likely pathological if they give it to you in a question, and if it's not, you should be easily able to debunk whether or not it's pathological and just move on. Alright, so that's S3, and why is it related to mitral regurgitation or heart failure? Well, for one thing, S3 you can see is starting to happen right when the mitral valve opened, right? It's happening when you're in your rapid ventricular filling, you're putting a lot of blood into your left ventricle from the left atrium. That's what happens when the mitral valve is open. So S3, they tell you, is increased filling pressure, right? Which means that your left ventricle is having to work a little harder to put blood into your left ventricle. During mitral regurgitation, right, your valve was kind of opening up backwards, and some blood was coming back from the left ventricle into the left atrium. So there's going to be extra volume in the left atrium, which is why you would have increased filling pressures. In heart failure, everything goes bad, generally speaking, right? Heart failure is terrible. And one of the ways your body tries to compensate for heart failure is by increasing blood pressure. It is by increasing sympathetic output, right? So you want to make sure that you check for heart failure in a patient you hear in S3. So now that finishes up all of that. Oh, there's one last note I put right here, by the way. S3 and S4 are heard best at the end of expiration, right? You have to remember that breathing in and breathing out does have an effect on volumes in the heart. And the main effect it has is that when you breathe in, you bring more blood back to your right heart, right? More blood comes back to your right heart. So that's what inspiration does. So expiration is the opposite of that. Your heart is kind of going to be empty during expiration. And remember how S3 and S4 are both diastolic, right? They're both diastolic heart sounds. They're both heart sounds you hear during the filling of your left ventricle and right ventricle. So they're both actually really, really loud right at the end of expiration, when you're done breathing out, which is also going to be about the same time when your ventricles have finished contracting, right? Finished contracting, because this is during your diastolic phase. When you're at end expiration, remember in inspiration you're doing diastole, you're kind of filling up your heart. Expiration, when you breathe out and you actually hold your breath out, it's actually a lot easier to hear these things. One of the other reasons it's easier to hear these things is just because your lungs are emptier, so your chest wall actually gets closer to your heart, right? And then your step is going to be closer to your heart too. It's a really silly thing, but I got this note from a Euro question which actually asked, like, oh, when would S3 be louder, right? Or what could you make the patient do to make the S3 sound loudest? So you just tell them to breathe out and hold their breath and just like not breathe in for a little bit, so that their chest wall is actually closer to the heart itself, right? And that's really all there is for that. This is also a pretty common note here, so I wrote here, so if you hear an early diastolic S3 gallop, then suspect mitral regurgitation or heart failure, and the issue is increased left ventricular and systolic volume, right? And systolic volume, which means that after your left ventricle finished contracting, you had too much volume still left in your left ventricle, right? And that's going to be a sign of mitral regurgitation and heart failure, right? Because it's systolic heart failure more specifically. You were unable to get the blood out of your left ventricle, so now you have a lot of blood left in the left ventricle, and that makes it very, very difficult to add new blood into the left ventricle, right? So you're going to have increased filling pressure. Both of those case scenarios are your S3 gallop. Early diastolic S3 gallop gets described in a question all the time. If you hear a late diastolic S4 gallop, then the issue is decreased left ventricular compliance due to hypertension or any kind of hypertrophy of your left ventricle, right? Anything that's making it stiff. These are both different kinds of descriptions you could be given for the heart for any patient you get. So now here we're looking at a couple more graphs of the same stuff we were looking at last time, right? You have your pressure volume loop, right? So we kind of already talked about all this already, so we don't really need to go into it too much. But basically, last time we learned the two different lines that are not given in the book, right, are your contraction curve and how to figure out contractility, right, whether or not contractility changed, and then your compliance curve, whether or not compliance changed, right? Compliance doesn't tend to change very often, but contractility does change depending on what the scenario is that's pathological, and you want to be able to make sure you catch that, right? They're showing you more comparisons in these images over here, related to the same pressure volume loop, and here you have your cardiac cycle, right, with your left ventricular volume and your left ventricular pressure as we looked at it just now, right, and diastolic volume and systolic volume, etc., everything. You should be able to figure that out when you see a graph, because you actually studied the graph and you know what it was telling you. Right? The graph is no longer something that you don't understand, or should have never actually been something you don't understand. It's just intimidating because they combine 7 different lines at the same time. But it's important because it all is happening at the same time. Right? And keep in mind that all of this is happening within 1 second. Right? Within 1 second. Different parts are happening in different 0.1 second differences. Literally just every 0.1 second something happens. And that's pretty significant. Right? So there's a 0.1 second difference between this entire loop basically happens within 1 second as well. Right? Time isn't even on this graph, but you know because of this graph, which has time on it. And we basically already saw these examples as well, right? So you can see this one here, this pressure volume loop is showing you dilated cardiomyopathy, right? Where in all 3 of these, the red is the pathology, the black and white in the back is the normal one. So you can see in dilated cardiomyopathy, the issue is that the ventricle is very dilated, right? So there's without compensatory thickening of the wall, right? Dilated cardiomyopathy occurs with the ABCDs, all those different things that can cause it, like alcohol, beriberi, Coxsackie and Chagas disease, and doxorubicin, all of those stuff, right? Hemochromatosis as well. So dilated cardiomyopathy, the ventricle becomes dilated without compensatory thickening of the wall. The left ventricle is unable to pump enough blood to meet the metabolic demands of the organism. The end systolic and diastolic volumes increase. Right? So you can see that this point here shifted, and that point also shifted. The ESPVR, end systolic pulmonary venous. Wait, let me see. ESPVR and EDPVR. Yeah, your end systolic and end diastolic pressure volume basically are shifted to the right. The whole thing shifted to the right. You can see they labeled the ESPVR up here, which is basically your contractility, and then your EDPVR, diastole, has to do with compliance, right? Diastole is always going to be related to compliance. If you're filling your left ventricle, it should comply and expand. If your left ventricle doesn't expand as it's being filled, there's low compliance, and that's a bad thing, right? And up here, systolic one, this is with your contractility, right? How much contractility do you have? So you can see, you have to remember with dilated cardiomyopathy, the problem was not filling, right? Filling the heart is easy. It's so dilated you could fill it up all you want. The problem with diastolic, the problem with dilated cardiomyopathy was with the systole, right? You can see contractility has a lower slope now. The slope of contractility went down, right? You need to make this line for yourself on any graph you're given, and you can see that the contractility has decreased because the ventricle is so dilated in dilated cardiomyopathy that it can't really contract, right? Because you didn't do the compensatory thickening of the wall. If you don't thicken the wall and dilate at the same time, which basically means having a bigger heart in general, then it's not going to work too well, right? Decreased slope of the ESPVR for lower contractility, unchanged slope for the EDPVR because you have unchanged left ventricular compliance. It's complying just as well as it always was, and it's really, really big in there. Compare that to the other major pathology we learned about, which is hypertrophy, right? Left ventricular hypertrophy. This is not the same thing, and I'm going to mention this again, but basically all hypertrophy isn't the same thing. Hypertrophic obstructive cardiomyopathy, HOCM, is not the same thing as just left ventricular hypertrophy. Those are 2 completely different things. Left ventricular hypertrophy is usually something that happens because of hypertension, right? So this is going to be an increase in the thickness and mass of the myocardium. So now, when you look again at all the same curves you have, right, you can see that the compliance part, right, looks about the same, but up here contractility has changed, right? So you can see this could be a normal reversible response to cardiovascular conditioning, such as in an athletic person, or an abnormal response to irreversible response to chronically increased volume load or increased pressure load. Shown is a diagram of pathological hypertrophy reducing end diastolic volume and stroke volume. The thickening of the ventricular muscle results in decreased chamber compliance, and as a result, left ventricular pressure are elevated, the end systolic volume is increased, and the end diastolic volume is decreased, causing an overall reduction in cardiac output. You could tell stroke volume has decreased significantly, right, because the graph got thinner than the black one behind it. So stroke volume has decreased significantly. It's kind of hard to tell that compliance changed on this image because it does look like the same line, so we're going to assume compliance is okay. We won't really talk about that. But in ventricular hypertrophy, in actual ventricular hypertrophy, compliance is not that good because your ventricle is so thick that the space inside is very little now in the left ventricle, so you can barely put any blood in there, which is why your stroke volume decreased, and your compliance isn't going to be that good. If you're trying to put more blood into this really, really thick left ventricle, it's not going to expand. Right, so compliance is going to be the real issue. On your test, it should be very clear that this compliance curve isn't really matching up to what you have here. Shouldn't be the same curve, but here it does look like it is the same curve, so it should not be the same curve though. Right, and contractility will be much better, right, because it's such a thick curve. It's such a thick myocardium now. Right, so you can see that the orange slope, which is your new slope, is higher. The contractility slope is higher now because you can really contract very, very, very hard because you have so much extra muscle mass in your myocardium now. Right, so that's ventricular hypertrophy. The last thing here is your restrictive cardiomyopathy, which is also listed. You talk about all three diseases on the same pathology page when we get there. Restricted cardiomyopathy includes a group of heart disorders in which the walls of the ventricles become stiff, but do not necessarily become thickened, and resist normal filling with blood between heartbeats. Right? So restrictive, just like the name says, there's a lot of extra shit in your heart now, whether it be transdiuretin or iron, copper, whatever it has to be. Copper in Wilson disease causes restricted cardiomyopathy. So there's a lot of shit in your left ventricle now, the wall of the ventricle, so it doesn't really expand. It doesn't expand anymore. It becomes really stiff. This condition occurs when the heart muscle is gradually infiltrated or replaced by scar tissue, like after many MIs, or when abnormal substances like amyloidosis, transdiuretin accumulate in the heart muscle. The ventricular systolic pressure remains normal, diastolic pressure is elevated, and the cardiac output is reduced. Right, so you can see again, stroke volume has reduced because the red curve is thinner. The red curve is thinner than the bigger black normal curve, right? And you can see the contractility slope is the same as the original slope. Right, so contractility didn't get affected, but compliance did. You can see that the curve went higher. When the curve goes higher, compliance has gone down, right? Because this is pressure on the y-axis. Going up on the y-axis means you need more pressure to fill it. If you need more pressure to fill it, compliance is not that good. And that's all that happens in your restricted cardiomyopathy. So you can see there's an overlap between restrictive and left ventricular hypertrophy. Right? In restrictive and left ventricular hypertrophy, you lower your stroke volume in both of them. However, look at the contractility, right? Because in ventricular hypertrophy, contractility is really, really freaking good. There's all this extra muscle. It just pumps like a beast, but doesn't really fill too well. Right? So you can see contractility is the major difference between the two guys. Right? Much higher pressure in the left ventricle with your hypertrophy as opposed to restrictive. Restrictive has pretty much normal pressures. JVP we just talked about earlier, right? We compared the JVP, which is your right atrial pressure, with your left atrial pressure, and we looked at how it's very similar, and understanding all the parts of it are very much straightforward stuff. So it's not the hardest thing, right? So we saw A is your right atrial contraction as well as your left atrial contraction, right? If you're talking about the left atria, these would be the curve for your mitral valve. Since we're talking about the right atria, this is the curve for the tricuspid valve. Pretty much every time there's a lot of pressure on top of the tricuspid valve, you're going to have a wave going upwards, a bump going upwards. When your tricuspid valve has decreased pressure on it, you'll have the descents. I said right atrial contraction, you get this part. C is bulging of the tricuspid valve during right ventricular contraction. Right, so when the right ventricle contracts under and the tricuspid valve is closed, you kind of push the tricuspid valve up a little bit. Right, so you get a tiny bump in pressure there. Then you have right atrial relaxation. When your right atria is relaxing, there's barely any pressure on your tricuspid valve. Right. Then you start adding blood. Right, continued inflow of venous blood. You start adding blood into your right atrium. Right atria relaxed. Then you started adding blood into the right atria. That's your V, the filling phase. Right, it's also the diastolic phase. Right here, when you're adding blood into the right atrium, you have increased pressure. Then you have passive emptying of the right atrium after the tricuspid valve opens. Right, so this is just adding blood into the right atrium, then emptying it back into the right ventricle, and that's it. And after you empty it, this little phase is going to repeat again into atrial contraction. Right, so after tricuspid valve open, your right atrial will contract, squeeze everything into the right ventricle the best it can, and that's kind of going to be a repetitive loop that's just going to keep happening over and over again. Within 1 second, this entire thing happens. So over here, we're looking at the same JVP curve in a little more depth, right? With this is an image from Amboss, and then these two other images are just images I found online, which kind of point out systole and diastole for you, right? So you can see systole as compared to the left ventricle or right ventricle, whichever one you want to look at, right? When you're looking at the ECG, you're looking at ventricles for the most part. When we're looking at central venous pressure, you're looking at the right atrium. Right, so you can see the overlap here where between basically your QRS and up to the T, you have your systole stuff. Right, QRS is your ventricular contraction, so that is systole, and that's the entire part where your pressures in the atria are really, really low. Right, and then you have the diastole phase where your pressure in the atria starts going up again. Right, pressure starts going up again until you finally contract the atria. When you contract the atria, you start going down again, and so on and so on. It just keeps repeating. And feel free to pause it at any point to read any of these other notes. But this was a pretty cool question from Amboss, right? So they gave you this image, and then they asked you, a 57-year-old woman comes to the physician because of a 2-month history of intermittent dyspnea and dizziness. She has a history of mitral valve stenosis. Her pulse is 125 per minute and irregular, and blood pressure is 102/66. A transthoracic echo shows no valvular abnormalities. Which of the following elements is most likely to be absent from this patient's JVP waveform? Right, so her irregular heartbeat pretty much told you that she has AFib, right, atrial fibrillation. And if you have atrial fibrillation, atrial contraction is not going to be happening very well. So the A wave is just going to disappear. That's part 1 right here. Right, so you could tell that they gave you a JVP, but they didn't label it A, C, X, V, and Y. They didn't label it like that, right? So they don't have to. They don't have to, so make sure you do remember how to label your JVP as well. A lot of students kind of overlook the JVP and they think it's like a whole different world and they don't really want to understand it or memorize it. But it's not. It's actually the same heart that made your left ventricular pressure curve, the same heart that made your left ventricular volume curve. All of those curves are on the same graph because they're all part of the same heart and they're all happening simultaneously. Right, so atrial contraction is going to be gone, and that's this first part right here where pressure in the right atria is super high. Right, then you have this part 2 here where you just finished contraction. Right, so now you're going to be, if your right atria just finished contraction, then the next thing is going to be your right ventricular contraction. Right, and then you're emptying it all out. Right, and then you have your your 4 again where you're filling it again, and then you're going to go towards contraction. Right, so part 4 is you're filling it so you can come back to your atrial contraction again. And that's it. Very straightforward stuff, nothing insane. Right, so the A wave disappears in atrial fibrillation is a pretty high yield topic to know because atrial fibrillation is a pretty high yield topic to know. The next thing we see here are a couple more images. Right, so I have images throughout the book for anyone that's interested in buying it. Like, one of the best things about the book is that there's a lot of extra images throughout the book, collection from Amboss and New World and stuff, all credits given, because these images help you really master the topic. And some of these are going to be images you might have never seen before. So we have 2 different x-rays here. On the left, we see a PA and lateral close-up showing thick pericardial calcification around the apex of the heart from a patient with a history of tuberculous pericarditis. So if you do look at this x-ray, right, you can actually see, compared to this one over here, you can actually really see this portion right here. There's something really white that's standing out very evidently. That's the calcification they're talking about. Right, it's here too, but it's not very prominent. Here you can see like a thin lining around this pericardium. That's also the same thing. Right, same thing. So PA and lateral, it's much more visible on the lateral aspect. Right, thin eggshell-like calcification is more often associated with viral infection or uremia. Calcification from old TB is often thick, confluent, and irregular in appearance, especially when compared with myocardial calcification. And this is pretty thick, right? You can really only have good visualization of it laterally because when you do the PA, you're not really seeing the entire heart because of the way the heart is actually placed in the chest. So here you can't really see too much of it, but laterally you can see how thick this is. Right? This is going to be related to one of the questions that's coming up soon enough. Here, this is from Amboss, this image where they highlighted something for you. So this is a pericardial thickening and calcification of the pericardial contour right, which indicates pericardial fibrosis. Additionally, right-sided pleural effusion and prominent perihilar lung markings are suggestive of pulmonary stasis, all indicating constrictive pericarditis, right? So over here, all that junk you see over here, that's that perihilar lung marking, because the hilum of the lungs is right here, and when you're looking at it laterally, you're looking at it from either side. They're looking at the patient from the left. You can see that this should pretty much be clear. This is the hilum of the lung. There shouldn't be a lot of crap in there, but there is. And when there's a lot of crap in there, you know that something's not right, right? And this is all pulmonary stasis, right? From perihilar lung markings. This guy has pericardial constriction as well. So all of that comes down to constrictive pericarditis. And it's going to be related to a question. So let's take a look at these two questions right here. First one we have, Amba, a 63-year-old man who recently immigrated to the United States from Indonesia, comes to the physician because of worsening shortness of breath and swollen extremities for the past 3 months. He has had a 4-kilogram weight loss and intermittent fevers over the last 6 months. Examination shows pitting pedal edema and abdominal distension. Abdominal pressure over the right upper quadrant produces persistent distension of the jugular veins. An X-ray of the chest shows cavernous infiltrates in the left and right upper lobes and a calcified cardiac silhouette. Cardiovascular examination is most likely to show which of the following. So when they describe all of that stuff to you, there's a lot of pathologies you can easily knock out. Like, you know what's not happening to this patient, but now you have to look at your differential diagnoses and pick one that you definitely think is happening to this man. Right, so 63, he recently came from Indonesia. So you know he doesn't have many of his vaccinations, and he's 63, so his immune system is starting to get real weak now. He has shortness of breath, swollen extremities. Sounds a little like heart failure, right? He's lost weight, right? 4 kilograms. He has fever, so most likely some kind of infection. He has pitting pedal edema, right? Pressure over the right upper quadrant makes him have your distension of the jugular vein, right? So when he's putting pressure on the right upper quadrant, right? Pressure on the right upper quadrant, he's getting jugular venous distension, JVD. And then when they do a chest x-ray, which is great information, you're seeing infiltrates in the left and right upper lobes and a calcified cardiac silhouette. So now, because this person is coming from another country, I really want to think this might have something to do with TB, right? And then you look at all your answer choices, you know that there's calcification around the cardiac silhouette. So the best answer to pick was a pericardial knock, right? Cardiovascular examination will give you a pericardial knock. A pericardial knock is often heard on auscultation in constrictive pericarditis, in which diastolic ventricular relaxation and filling are abruptly halted by the rigid pericardial sac. Right? So this rigidness is pretty special here. Right? A pericardial knock is a high-pitched early diastolic sound that sounds like a premature S3. In constrictive pericarditis, reduced ventricular filling leads to manifestations of reduced cardiac output, such as fatigue, dyspnea, as well as those of fluid overload, such as JVD, positive Kussmaul sign, hepatomegaly, and the clinical features seen in this patient. So that's that. Then you have your next question from Amboss as well. Prior to undergoing a total knee arthroplasty, a 62-year-old man with coronary artery disease undergoes cardiac catheterization. The catheter is inserted via the femoral artery and advanced to the ascending aorta. Right, so you should know by now what kind of catheterization is happening right now. Pressure tracing of the catheter shows a pressure curve with a maximum of 120 that is followed by a smaller peak of 100 before gradually decreasing to 80. Right, so you should know exactly where this pressure is too, because we just talked about all the pressures, right? 120 to 80. The second peak is most likely due to what? Right, so what is that second peak? Where the pressure went from 120 and came down to 100 and something happened. Right, and then I'm also pointing out the peak on this image right here, which was in the explanation. So we already talked about this, right? We saw the pressure going from 80 to 120. Then when it comes back down, about at 100, something happens. And that's kind of what they're asking you about. And then you have your second peak here, right? And that second peak is what the real question is about, right? So that part is exactly where your coronary vessels get perfused. So they tell you, closure of the aortic valve is associated with a small backflow of blood toward the left ventricle from the aorta, right, coming back into the left ventricle, except it won't go back into the left ventricle because your aortic valve is closed. So it'll smash into the left ventricle, and then it'll go into your left and right coronary arteries. Right? This causes a slight decrease in the aortic pressure as the blood refluxes toward the closed valve, followed by a transient increase in pressure as this blood is reflected back into the lumen of the aorta. This process accounts for the dicrotic notch and secondary upstroke in the pressure tracings. This point is also basically when the coronary arteries are perfused during diastole, right? Coronary arteries are perfused during early diastole, right? As soon as your aortic valve closes, there's a little bit of blood that comes back, smashes into the aortic valve, then goes back upwards, as well as goes into your left and right coronary arteries, and that's what this portion right here is about. So these pressure readings are really significant and very easy to remember, right? You can easily reproduce this graph as well as all the other lines on that 7-line graph without even having to look at it. That's how well you should know it, because it's all pretty much stuff you've looked at for a very long time, and you keep looking at it and keep studying it and keep trying to understand why each of those curves are the way they look, you'll master it, right? You'll master it, you'll know exactly what it does, you'll know what it's about, and you'll be able to reproduce it, right? So you won't even need to worry too much about what it's supposed to look like and what's pathological, because we're going to be looking at a lot of pathological images now. Right, so in the 2019 first day, they did this nice thing where they pretty much gave you all of these images, telling you how the different pathologies can look like. Right, these are all pathological images that you've seen already when you did your first aid questions, right? Sorry, not first aid, when you did your UWorld questions, right? UWorld always had images like this one over here, for example, or this one, any one of these, right? And from UWorld, these are the images that you were given, right? You can see this graph. You saw all of these different graphs from UWorld based off of whatever the issue was, and you were able to master what was happening. Right? Oftentimes the graph can even be given like this, where they label A, B, C, D, and E and ask you about different parts of it. So you really have to dissect this graph for yourself and know exactly what's happening at each part. Right? It's not a guessing game. It's definitely not a memorization game. It's just reading the graph as time is growing. Right? Remember, the x-axis was time and the y-axis was pressure. As time is going, pressure is changing, and based off of those changes in pressure, different valves are going to open and different valves are going to close. Right? And also keep in mind that all of this happens within 1 second. Right? This was in breaks of 0.1, 0.2, 0.3, 0.4, all of that. So the whole thing basically takes place within 1 second. Right? Within 1 second, the whole one thing happens. So they give you 2 bumps here, and you're supposed to be able to see the differences. You can see there's a big difference between these two. Right? Mitral stenosis, aortic regurgitation. This is the normal. I took a snippet from the earlier part that we were studying. This is the normal graph, right, where everything goes together. You have a dicrotic notch. All of that is normal. So let's take a look at each one of these scenarios, right? So the first scenario, we have aortic stenosis. So basically, you're going to need a lot of pressure to open your aortic valve. So if you're going to need more pressure to open your aortic valve, if you look at it, you can see that the curve went way above 120. Right? It's not supposed to go above 120. But left ventricular pressure went way above 120. The other thing you're noticing is that the pink line did not go with it. Right? The pink line was supposed to go together like that. Right? It's supposed to go together, but it didn't. So your left ventricular pressure is way above aortic pressure. This one little portion right here. So this definitely looks like aortic stenosis. Over here on your pressure volume loop, remember the aortic stenosis decreased your stroke volume because you had to put in a lot of pressure to get it to open. And then as soon as pressure came down, the aortic valve immediately closed. So a lot of blood didn't even get out of your left ventricle. So you can see your end systolic volume, which was supposed to be 100, is now more than 100. Right? So it's like 140. End systolic volume increased. Right? This point down here was your end systolic volume. This point here was end diastolic volume, because your x-axis is all volume. So if you're filling, that's diastole. So if you started here, that's end systole, at the end of systole, and then when you finish here, that's the end of diastole. So you can see your end systolic volume increased. And your pressure is super high because you need a lot of pressure to open your aortic valve, and then it closes immediately. As soon as pressure goes down, your aortic valve just closes super quickly because it's stiff. This is eventually going to lead to ventricular hypertrophy because your left ventricle is working really hard to pump against this stiff aortic valve, and this ventricular hypertrophy will decrease your ventricular compliance. Right? Ventricular compliance will decrease, and you're going to have a higher end diastolic pressure for any end diastolic volume. Right? Higher end diastolic pressure for any end diastolic volume. And you can see that, right? Because end diastolic pressure is not supposed to be super high, but it is. Look at how high the pressure is here, right? Super high pressures, and that's not good for you, right? Also, if you were to do the lines that we were supposed to be graphing from what we talked about earlier, right? So you can see the slope for contractility pretty much matches in both of these graphs, right? They have the same contractility. Contractility won't be a problem here, right? Because it's not at that point yet. You're still going to contract at the same point until ventricular hypertrophy happens. Once ventricular hypertrophy happens, then compliance and contractility will both change. So you're going to have a more, your slope is going to be more like this. You're going to have a higher slope for contractility because it's going to contract really well after the hypertrophy, and your compliance isn't going to be that good. You're going to have a higher compliance curve, which means there's a lower compliance actually in the heart because it's very hypertrophied, too much muscle. Then you look at mitral regurgitation, right? So you can see the pressure volume loop for this guy looks pretty cool. Very weird looking pressure volume curve, right? For both mitral and aortic regurgitation, there's a very circular looking pressure volume loop. Like, it just doesn't look like it has any edges anymore, and this is something that a lot of students had not seen before First Day 2019. I did have it in my PDF during the First Day 2018 edit, but I took it out now that they put it into their First Day 2019. So this is pretty nice. So let's look at mitral regurgitation. Mitral regurgitation basically means that your mitral valve never actually closes, right? That's what's happening in mitral regurgitation. It opened from the left atrium into the left ventricle, sent blood from the left atrium into the left ventricle, then it's supposed to close, and then when your left ventricle contracts, it should open the aortic valve. But it's actually also going to open your mitral valve and send blood backwards from the left ventricle into the left atrium. Right, so that's what you're going to start seeing here. So first thing you see, that the top stuff is all fine. So left ventricular pressure is fine, aortic pressure is following it, and everything is at 120. That's good. Down here, this green line was supposed to look like that, but it doesn't. Right, so what happened here? Well, mitral valve was supposed to close here. Right, mitral valve was supposed to close here, and then left ventricular pressure would start increasing, and as left ventricular pressure increased, aortic valve would open. But look at this, your mitral valve pretty much didn't really ever close. Pressure is being emitted into your left ventricular pressure is being emitted into the aortic area too, but as you know, you're also sending a lot of it into your left atrium. Right? Remember this green line for the mitral valve? This is your left atrial pressure. So an increase in your left ventricular pressure is being emitted into both the aorta as well as left atrium. And the only reason pressure would be emitted into the left atrium is because your mitral valve is open. So you get a tall V wave. That's what they call this. This is a tall V wave. And then when the pressure starts coming down again, it comes down with the left atria as well until it finally opens. Right? And then over here, the pressure is going to be low enough for the mitral valve to open up again. So this is a very clear sign that this is mitral regurgitation. Right? Pressure from the left ventricle is being emitted into the left atrium, and it shouldn't be. So overall, this is going to lead to an increased stroke volume though, because you're not going to send all the blood from your left ventricle into the aorta. A lot of the blood went back to the left atrium, and then of course from the left atrium is going to come back to the left ventricle. You're just sending blood back and forth between the left ventricle and left atria. Eventually all of that is going to keep adding up, and you're going to have too much blood in your left ventricle. Right? So you have a low end systolic volume due to decreased resistance and more regurgitation into the left atrium during systole. Right? So end systolic volume has decreased. And end diastolic volume, which is your filling, you're going to have a lot more blood to add now. First, you're going to add the normal blood that you're supposed to add from the left atrium into the left ventricle anyway. And then you're also going to add the blood that regurgitated back from the left ventricle, again sending it to the left ventricle. So that's double. Right? So it's going to be a lot of blood that you're going to be adding, so you have a higher stroke volume as well. Here you see aortic regurgitation. The most iconic thing in your aortic regurgitation is usually supposed to be, I think we see it with, let me see, yeah. You see how you don't have a dicrotic notch anymore in the aortic regurgitation? UWorld shows it to you. Right? This is the UWorld image for aortic regurgitation, and you can see that the dicrotic notch, right, this part right here, is pretty much gone. There's no dicrotic notch. right? In first aid, they didn't really take it away. They didn't take away the dichrotic notch. What they do show you is this thing here, right? This weird stuff that's happening right here at the beginning. It's supposed to look like that, but it doesn't. Right? So what you're seeing is as time is going, pressure is already increasing in your left ventricle, even though your mitral valve isn't exactly done doing its job. Your mitral valve hasn't per se closed, right? Because your mitral valve has to close, and then pressure builds up in your left ventricle, right? But that's happening way too early, way too early. Right over here, your mitral valve already closed, or maybe it didn't, because it is generally supposed to close right here, right? And then you start building up pressure in your left ventricle. The top and all of that generally looks the same, but there won't be a dichrotic notch. Now, why won't there be a dichrotic notch? Well, the dichrotic notch, remember, happened because some blood came back from the aorta onto the aortic valve, smashed into the aortic valve, then went into coronary vessels, and of course jumped back upwards again, and that's how you get your dichrotic notch. But now, with the aortic regurgitation, regurgitation generally means the valve never closed. So let's go back to the Euro one. So since the valve never closed, it's almost like it was open the whole time. So when blood comes back smashing into the aortic valve, it kind of opens up again and brings black blood into your left ventricle, right? So that's what happens when your aortic valve is very regurgitant, right? So you can see your mitral valve closed earlier, right? It's generally supposed to close over here, right? But it closed a lot earlier, right? Because left ventricular pressure does not start increasing until the mitral valve closes. So mitral valve closed, left ventricular pressure started building up, right? And you get this weird little slope over here, and then it keeps going, everything happens, and then it closes again, right? And you can see your left atrial pressure is pretty much the same, nothing happened wrong with that. But this entire curve looks kind of weird, it looks kind of funky compared to this one. Right, let's bring this down here just for comparison. Right, if you look at the normal one to the right, and this one here, right, this solid red line is a solid hump. It's a very solid hump right here. But here you have this weird leg at the beginning, and then you get your hump. And the dichrotic notch is gone. There's no more dichrotic notch. Now on your test, whether or not the dichrotic notch will be gone, I can't say. I'm not 100% sure. It should be gone if it's aortic regurgitation. But if the dichrotic notch is not gone, this is still something that will definitely happen in aortic regurgitation. Right? On top of that, aortic stenosis, which we already talked about, is a whole different thing. Right? Aortic stenosis means your left ventricular pressure has to go super high to open the aortic valve. They don't even go up together. So you can't confuse that at all, right? Whereas with mitral issues, you're going to have an issue with the left atrial tracing, as you see here, or as you see here. This last one is mitral stenosis, where on the pressure volume loop, you can see because the mitral valve doesn't really want to open very well, you're not going to put a lot of blood into your left ventricle, right? So systole is fine, but your end diastolic volume has pretty much halved. Right, it came down so much. It was supposed to be up to two, not halved. You lost half of it. You lost half of it, right? You were supposed to go from 100 to 200, but you only went up to 150. So in essence, it has halved, right? The volume was going to be 100, now it's 50. Right, so in here it's only 150 when it was actually going to be almost 200 if it went all the way, we're imagining. So because of mitral stenosis, your left atrial won't be able to open. You won't be able to put too much blood in your left ventricle, and your stroke volume decreases. So stroke volume decreases, end diastolic volume decreases. Yeah, and then that's generally all you're kind of seeing, right? So decreased end diastolic volume, decreased stroke volume. End systolic volume being lower isn't necessary. This isn't 100%. You're not always going to see that in mitral stenosis. And of course, the biggest thing that you can even measure with the PCWP is that there's going to be increased left atrial pressure, right? You're going to have to add a lot more pressure from the left atrium to open the mitral valve into the left ventricle. So now you can see over here with this cardiac cycle curve again, that the top is perfectly fine because nothing's wrong with the left ventricular pressure, nothing's wrong with the aortic pressure. But this green curve is all fucked up, right? The green curve is all about left atrial pressure, and left atrial pressure is going to be very high in mitral stenosis. This is one of the things we always measure with PCWP, Right? Your PCWP is going to be high. Your left atria has to contract really, really hard to even open the mitral valve so that you can send some blood into the left ventricle. Right? And that's all that happens. So basically the curve still looks the same, it's just much higher. Right? The curve looks the same. It's the same design that it has over here. Right? Same design that it has over here. The design of the curve didn't change, but it's just at a much higher pressure. Before it was closer to 0. Right? It's always been at 0. Now it's almost at like 40 over here. 30 to 40. So, you know, there's a big increase in your left atrial pressure, and that's not normal. Your left atria should not have any pressure. Eventually, this high left atrial pressure, right? Left atrial pressure is high because it takes higher pressures to open the stenotic mitral valve. This pressure is transmitted backwards to the lungs and also causes an elevated PCWP. But eventually, this is also going to cause your left atria to become bigger, right? It's going to lead to left atrial enlargement, and that's not good for you either. And all of this is going to be problematic, and you need to fix this before you get irreversible changes. Right? So those are all your physiological changes in valvular disease, displayed graphically. Now, there's no real explanation for how mitral and aortic regurgitation kind of look different from each other as far as the pressure volume loop is concerned. They both look like a bean. It's a circle. And this is because there's no hardcore, edges anymore. Right? Remember, regurgitation, I always think of regurgitation as a valve that never closes. It opens in one way and then it opens the other way now. So because of that, you don't have solid curves occurring. It's a circle. Right? So you're almost never going to be given just a pressure volume loop and expected to know, whether this is mitral regurgitation or this is mitral regurgitation, because they're not that different from each other. Right? They still span from the left to the right about the same. They also span from the bottom up about the same. So there's really nothing that you can look at to identify it. You would have to be given this curve or be given more information to really identify whether it's mitral regurgitation or aortic regurgitation. Right, so we just talked about all of these. Now feel free whenever you want to pause any of these to read extra notes about the mitral regurgitation. Right, then you have mitral stenosis notes right here. Right, and then aortic regurgitation notes. And lastly, aortic stenosis notes up here. A bunch of notes just from a collection of things that happened in various questions I must have done. And then we actually have a question here, and I'll leave it off at this. So let's check out this question. We have a 75-year-old man comes to the office due to worsening dyspnea and fatigue on exertion over the last 6 months. Recently, he's had severe lightheadedness during physical activity. Blood pressure is pretty normal looking. Pulse is 65 and regular. Physical exam reveals a harsh ejection type systolic murmur at the base of the heart radiating to the neck. The second heart sound is low in intensity. A fourth heart sound is heard at the cardiac apex. What is the most likely cause of his heart condition? Right, so initially you might have thought this is a patient with aortic stenosis, right? And that's going to be because this is a 75-year-old patient, and then you might have been like, no, it's not aortic stenosis because his blood pressure looks normal. Don't really doubt yourself off of one little thing over the other, right? Look at the answer. The answer was extensive valve calcification with impaired leaflet mobility, pretty much of the aortic valve. That's what's happening to him. And he has the symptoms of it. He has the syncope. He has this dyspnea, fatigue, right? All of these things because he's not able to send enough blood from his left ventricle into the body. On top of that, it's an ejection type murmur. So ejection, systolic murmur, is generally going to be during systole where your aortic valve has to pop open. His presentation is suggestive of aortic stenosis, which causes pulmonary vascular congestion leading to dyspnea and reduced mean arterial pressure leading to lightheadedness. S2, the closure of the aortic and pulmonic valve, is reduced due to impaired mobility of the aortic leaflets. S4, which is the late, right, the fourth heart sound heard at the cardiac apex, right, not late. The fourth heart sound is an early diastolic sound, right? Early diastolic sound is present due to decreased compliance of the hypertrophic myocardium, right? By this point, because of his aortic stenosis, his left ventricle has actually become very, very thickened, right? There's hypertrophy that's going to happen there, and that's really important to watch out for, right? They tell you calcific degeneration of the aortic valve is the most common cause of aortic stenosis in the developed nations. On the other hand, rheumatic valve disease is a common cause of aortic stenosis in developing nations and is characterized by fusion of valve commissures due to repetitive inflammation. Now, calcific aortic valve disease is similar to arterial atherosclerosis, right? The mechanism of calcific aortic valve disease is actually one that not many people know, so I actually learned it from MBOS pretty recently. It's very similar to arterial atherosclerosis. There's going to be endothelial lining of the AV cusp being exposed to high pressure and damage, which actually triggers inflammation. Very similar to how all the extra LDL triggers inflammation in your arteries, leading to atherosclerosis. And then something called osteopontin is produced, and fibroblasts differentiate into osteoblast-like cells, leading to aberrant bone matrix deposition with valvular calcification and stenosis. I didn't know this image was hiding that note. Let me just bring this up a little, right? There you go. Okay. Right, leading to aberrant bone matrix deposition and valvular calcific stenosis. So all of that happens. So there is a pretty big comparison between calcific aortic valve disease and atherosclerosis, and atherosclerosis is super high yield, so it can definitely pop up on your test as well. Very nice to understand how that entire pathophysiology works, and that's pretty much the end of that. These YouTube links are really pretty freaking awesome, actually, because they're right next to the sound that you're seeing. Is because if you want to hear the sound, then that's the link you go to. Right? So if you want to hear what mitral regurgitation sounds like, go to that link. Right? If you want to go to mitral stenosis, this is the link for that. You can find heart sounds on the internet all over the place. And heart sounds are very much like histology. You have to keep looking at histology to really be able to identify any pathology in a histoimage. And you have to keep listening to heart sounds to really get good at appreciating S1 and S2 and where in between the issue happened, right? So I'm going to talk a lot more about that when we get there, because heart sounds are the next topic. And in the next video, I'm going to describe to you why heart sounds are the way they are, how you hear them, where you're supposed to hear them, and what changes them. Alright, so thank you very much for joining today, and then I'll see you guys again in the next video.